It's really quite striking how interconnected everything in the body is, isn't it? You might think, okay, vascular surgery, heart health, maybe separate things. But actually, for people with vascular problems, their overall health, especially their heart, often turns out to be the main story.
Absolutely. The state of a patient's cardiovascular system is just. It's paramount when they're facing any kind of vascular surgery.
And that's exactly what we're diving into today. Our focus is really trying to understand the potential heart-related complications, the things that can pop up when someone has vascular surgery.
Right, and we're basing this on the material you shared chapters from the 10th edition of Rutherford's Vascular Surgery and Endovascular Therapy, which, I mean, it's a seriously authoritative and really comprehensive resource in this field.
It really is. So our mission today essentially is to pull out the crucial knowledge about these cardiac complications. We want to give you a clear picture, without getting totally bogged down in every single detail. Okay, so maybe start with the basics. Why are heart problems such a common worry for people needing vascular surgery?
Well, it really boils down to shared risk factors. Things like high blood pressure, diabetes, high cholesterol, smoking. These often lead to both atherosclerosis, hardened arteries throughout the body, which is vascular disease, and coronary artery disease, which is the same process happening in the heart's arteries.
Okay. So the same underlying issues are causing problems in both systems.
Exactly. So it's super common for patients needing vascular surgery to already have some kind of heart condition, whether they know it or not. And then on top of that, the stress of the surgery itself, the changes in blood pressure, blood flow, the body's inflammatory reaction, that can all put a significant strain on the heart.
That makes total sense. It's like hitting the same weak spots. And the sources mention that the risk of something called MACE, which I guess is like a collection of serious heart issues, is especially high in certain vascular surgeries.
Yes. AIM-ECE stands for Major Adverse Cardiac Events. And you're right, in higher risk procedures, think lower extremity bypass, aortofemoral bypass, or fixing an abdominal aortic aneurysm, and AAA, the rate of MACE can be, well, pretty significant, somewhere in the range of 10% to over 20%.
Wow.
Yeah, and unfortunately, the mortality risk, the risk of dying in those situations, is also elevated, maybe 2% to 3%. It really underscores how vital it is for the whole vascular team to be aware of these risks and ready to manage them.
Those numbers are, wow, they're pretty sobering, aren't they? So what specific things fall under this AME umbrella? What are we actually talking about?
The most frequent heart problems we see around surgery time are myocardial infarction. That's the medical term for a heart attack atrial fibrillation, which is that irregular, often fast heartbeat, and acute heart failure, where the heart suddenly can't pump effectively.
Okay.
And it's also worth noting that cardiac death itself often isn't just out of the blue. It can be the end result of a kind of cascade, often starting with some kind of injury to the heart muscle.
Right.
Okay, let's zoom in on myocardial infarction, MI. The sources really seem to emphasize this as a major concern for vascular patients.
Absolutely. A big concern. MI can happen in roughly 2% to maybe 17% of vascular surgery patients. That range is wide, partly because it depends on how exactly you define an MI.
Sure.
The development of the universal definitions of MI, starting back in 2007, was a really big step forward here. The latest version helps us categorize why someone might have an acute leak of cardiac troponin that's a blood marker for heart muscle damage. Is it ischemic, meaning due to lack of blood flow, that's called MI, or is it non-ischemic, that's termed myocardial injury?
So it's not just one type of heart attack, there are different categories.
Yes, exactly. And even within the MI category, there are different types. Types Phi and V are related to heart procedures themselves, like stenting or bypass surgery, so less relevant for us today. Type 3 is when someone has symptoms, then sadly has a cardiac arrest and dies before we can even get the blood tests back. If an autopsy later shows a clot in a heart artery, it gets reclassified as type Y.
But for our vascular surgery patients, the most common situations where we see the troponin rise are type I MI, type 2 MI, and then this broader category of myocardial injury.
Okay, let's unpack type I MI first, specifically in the context of vascular surgery. What's happening there?
Type I MI, in this setting, is usually kicked off by the stress of the surgery. The shifts in blood pressure and flow put mechanical stress on the artery walls, plus the body's inflammatory response. All this can cause an existing plaque inside one of the heart's arteries to rupture or break open.
And that triggers a clot.
Precisely. It sets off the clotting cascade right there. So to diagnose a type I MI, we need that typical rise and fall pattern in the cardiac troponin levels, plus at least one other thing, Symptoms like chest pain, new EKG changes showing ischemia, new imaging evidence that part of the heart muscle isn't moving right, or actually finding a clot during a heart cath or autopsy.
Okay, clear. And then type 2 MI, how's that one different?
Type 2 MI shares similar diagnostic criteria. The troponin rise and fall may be symptoms or EKG changes, but the key difference is there's no evidence of an acute plaque rupture causing a blood clot in the coronary artery.
So it can be tricky to tell apart sometimes.
It definitely can be, especially without doing invasive tests like a coronary angiogram. But if a patient hasn't had a cath and doesn't have those really specific EKG changes right after surgery, it's most likely a type 2 MI. In fact, this is actually the dominant reason we see cardiac enzyme leaks after vascular surgery.
Okay, so if there isn't a fresh clot blocking an artery, what is causing the heart damage in type 2 MI?
Often it's an imbalance between the oxygen supply to the heart muscle and the demand placed upon it. Think of it like this. Someone might already have some narrowed coronary arteries, stable coronary artery disease, but maybe not severe blockages. But then, during or after a major surgery, the heart has to work much harder. The oxygen demand goes way up. If the narrowed arteries, or maybe issues with the tiny microvessels in the heart, can't deliver enough extra oxygen to meet that demand, that mismatch can cause injury.
So the heart's running on fumes, essentially, because of the increased workload and the existing plumbing issues?
That's a great way to put it. They might not have the kind of critical blockage that causes a type I plaque rupture, but their system just doesn't have the reserve to handle the stress. It really highlights that even without an acute clot, the physiological stress of surgery can really tip things over the edge, especially if there's underlying vulnerability.
That's a really crucial distinction. Now, the sources also use the term myocardial injury. How does that fit in? Is it different again?
It is. With myocardial injury, you still see that rise and fall in cardiac troponin, indicating some heart muscle cell damage. But crucially, you don't see the other evidence pointing towards ischemia, no typical EKG changes suggesting lack of blood flow, no new wall motion problems on imaging.
So what is causing the damage now?
It can happen when the heart chambers, the ventricles, are under extreme strain, maybe from acute heart failure, a pulmonary embolism, or even just massive fluid overload. This physical stretching damages the muscle cells. Other causes could be severe metabolic problems, a huge surge of adrenaline, or even things like electrical cardioversion. It's damage, but not directly from a blocked coronary artery.
Okay, got it. Damage from strain or other stressors, not ischemia. I also saw MNs or PMI mentioned. What are those about?
Right. MNS is myocardial injury after non-cardiac surgery, and PMI is perioperative myocardial injury. Some have proposed using these as sort of umbrella terms for any troponin leak around surgery, whatever the cause. But the sources here point out this can ultimately muddy the waters because the universal definitions we just talked about already have a specific definition for myocardial injury. So there's a bit of, let's call it a terminology debate. But the absolutely critical takeaway, regardless of the label you use, is that finding an elevated high-sensitivity troponin after surgery is strongly linked to increased mortality both at 30 days and even out to 1 year. It's a major warning sign. The sources quote, about a 10% 30-day mortality rate, and for vascular surgery patients, the odds ratio is significantly higher, around 3.7, compared to those without elevated troponin.
Wow, okay. So, label aside, elevated troponin post-op is seriously bad news. The sources also mention a potential spiral of worsening heart function. Can you walk us through that concept? It sounds ominous.
Yeah, it illustrates how these different cardiac issues can feed into each other, creating a dangerous downward cycle. So imagine someone has a significant type I MI, or maybe a new MI hitting a heart that already wasn't pumping well.
Right.
Well, that initial hit might then lead to a type 2 MI. Why? Because the remaining healthy heart muscle is now working overtime, demand is up, but maybe supply can't keep up, or the overall pumping function just drops.
Okay, so one problem leads to another.
Exactly. And then the main pumping chamber, the left ventricle, might start to dilate, to get bigger, trying to compensate. But that stretching puts more strain on the muscle walls, potentially causing that non-ischemic myocardial injury we talked about.
And it just keeps getting worse.
Potentially, yes.
Yes.
If this cascade continues, the patient can end up in cardiogenic shock. The heart simply can't pump enough blood to keep the body going. And sadly, the chances of survival once you reach that stage are often quite low. Figure 44.1 in the text gives a good visual of how these things are linked.
Yeah, that paints a really concerning picture of how things can snowball. Let's switch gears slightly to another big cardiac issue. Congestive heart failure, CHF. How does that fit into the risk landscape for vascular surgery?
CHF is definitely another major player. The reasons someone might develop or worsen heart failure around vascular surgery are pretty varied, and sometimes it's tough to nail down one single cause. But any pre-existing problem with the heart valves or the main ventricle's pumping or relaxing ability makes a patient much more vulnerable to the fluid shifts and stresses of surgery.
And it's pretty common in this patient group.
Yes, CHF is present in a good chunk of older patients having major non-cardiac surgery. And its presence is a really strong predictor of bad outcomes, dying during or soon after the operation, being readmitted to the hospital. Maybe even more predictive than known coronary artery disease in some studies.
Does the type of heart failure matter here?
It seems to. Patients with heart failure with preserved ejection fraction, HFpEF, where the muscle contracts okay but doesn't relax well, generally seem to fare a bit better perioperatively than those with heart failure with reduced ejection fraction, HFrEF, where the muscle is weak.
Okay.
And the worse the pump function is in HFrEF, the worse the outcomes tend to be. It's no surprise then that having CHF diagnosed before vascular surgery significantly increases mortality and length of hospital stay. We see that clearly in patients having leg bypasses, for example.
So knowing about heart function before surgery is key. What tools do doctors use to check that?
A preoperative echocardiogram, that heart ultrasound, often called a TTE, and measuring those natriuretic peptides, NT-proBNP or BNP, in the blood are really important, especially if there's known or suspected LV dysfunction.
Can you remind us what BNP is again?
Sure. BNP stands for brain natriuretic peptide, though it's mostly made in the heart's ventricles, actually. It and its precursor NT-proBNP get released when the heart muscle is stretched by increased volume or pressure.
And high levels are bad.
Yes, higher levels are strong predictors of NE and mortality after vascular surgery. Now, there's some debate on who should get these tests. The Canadian guidelines lean towards testing more broadly, maybe for everyone having major risk surgery. But many places still reserve them for patients where there's already a clinical suspicion of heart problems.
Okay. Are there other specific heart conditions besides general heart failure that are particularly relevant here? The sources brought up valvular disease, especially aortic stenosis.
Right, valvular heart disease is definitely on the radar. Aortic stenosis, or AS, which is a narrowing of the main valve leading out of the heart, is quite common in older folks.
Yeah.
A tricky thing is that many vascular patients might have severe AS, but no obvious symptoms, maybe because their leg pain or other issues limit their activity so much they never really push their heart hard enough to notice it.
So it can be hidden.
It can be, and you can't reliably tell how bad the stenosis is just by listening to the murmur loudness. But one clinical clue surgeons should look for is a pulse in the neck or arm that feels weak and slow, to rise the classic parvus tardis pulse in someone who also has that harsh systolic murmur over the heart.
And severe AS increases surgical risk.
Yes, severe AS is definitely linked to increased ME after major non-cardiac surgery. The immediate surgical mortality risk has come down a bit over the years, but it's still high, especially in emergency operations, or if the patient also has AFib or kidney problems. Leaky valves, if symptomatic, are generally tolerated a bit better, but ideally should still be evaluated and optimized before elective vascular surgery.
Okay, so we've covered heart attacks, heart failure, valve issues. What about arrhythmias? Irregular heartbeats. The sources really highlighted atrial fibrillation.
Yeah, new onset atrial fibrillation, or AFib, is actually the most common arrhythmia we see pop up after vascular surgery. Happens in maybe around 5% of patients.
And even if it goes away, it's still a concern.
It seems so. Even if it resolves on its own and doesn't cause obvious symptoms, postoperative AFib is associated with a higher risk of ME, stroke, and death in the short term. It's likely acting as a marker for underlying risk factors.
What kind of underlying issues?
AFib often develops in patients who already have some structural abnormalities in their left atrium, the heart's upper chamber. This can be due to long-term damage from things like valve disease, poor ventricle function, chronic high blood pressure, basically things that cause the atrium to remodel over time.
And AFib itself can cause problems during surgery.
It absolutely can. It can actually precipitate perioperative CHF, especially in patients whose main pumping chamber doesn't relax well, like an HFpEF. Losing that coordinated atrial kick to help fill the ventricle becomes much more significant in those cases.
What about other, maybe more dangerous arrhythmias?
Less common, thankfully, but perioperative ventricular arrhythmias like ventricular tachycardia, VT, or ventricular fibrillation, VF, are much more serious. They're often triggered by ischemia, direct heart muscle injury, electrolyte imbalances, or that surge of stress hormones, catecholamines.
And patients with weak hearts are at higher risk.
Yes, patients with reduced ejection fraction preoperatively have a higher risk in developing these dangerous ventricular rhythms. And if they do occur around surgery, it unfortunately signals a higher risk of sudden cardiac death down the line.
Wow. This really drives home how complex managing cardiac health is in these patients. Okay, let's pivot to what can be done before the operation. How do clinicians actually assess and hopefully optimize a patient's cardiac risk?
Right, the whole point of the preoperative cardiac workup isn't just to clear someone for surgery. It's really about defining their specific level of risk and then figuring out if there are ways to mitigate that risk before they even get to the OR.
And teamwork is important here.
Hugely important, especially for high-risk vascular procedures. A multidisciplinary team approach what's often called a shared care model, involving the vascular surgeons, cardiologists, anesthesiologists, maybe others, that's really valuable for making these complex calls and coming up with the best possible plan. This kind of teamwork works well in other high-risk areas, like transplants, and it's even recommended in European guidelines for certain vascular patients.
Are there specific guidelines clinicians follow for this assessment?
Yes, there are several major sets of perioperative care guidelines out there. From the US, it's EAK, Europe, SCSA, and Canada, CCS. The US and European ones are pretty similar in their general approach to cardiac workup, focusing on predicting clinical events.
How do the Canadian guidelines differ?
The Canadian guidelines, updated more recently, tend to be a bit more conservative about extensive testing for coronary artery disease and put a bit more emphasis on cost-effectiveness. A key difference is their stronger recommendation for using biomarkers, those blood tests like troponin and BNP for risk assessment, both before and sometimes after surgery. While we often look to the US and European guidelines, it's good to know the field is always evolving.
You mentioned risk prediction. Are there specific scoring systems used for vascular surgery patients?
Well, the Revised Cardiac Risk Index, the RCRI, has been used for ages across all sorts of non-cardiac surgery, and it's referenced in the big guidelines. However, when you look specifically at vascular surgery populations, studies show its performance is only kind of moderate. It's not always great at picking out who's truly at high risk in this specific group.
So it might miss people or overestimate risk?
Potentially, yes. Because of that limitation, the Vascular Study Group of New England developed their own index, the VSG-CRI. And in their analyses, it seemed to be more accurate for predicting cardiac complications, specifically in vascular patients. It looks at things like age, smoking, diabetes, known heart disease, CHF, if they've had an abnormal stress test, if they're on beta blockers, COPD, kidney function.
Okay, more tailored. Is that the main one used now?
Well, even more recently, the Vascular Quality Initiative, the VQI, developed the VQI-CRI. This one's potentially even better because it actually has different risk models depending on the specific vascular procedure being done. There's an app, QX Calculate, that incorporates the VQI-CRI, and that's often our go-to now for estimating risk. The hope is, with better biomarkers and maybe AI down the line, we'll get even more personalized risk scores.
It sounds like biomarkers are definitely becoming more central. Let's talk a bit more about that preoperative blood work.
Yeah, as we touched on, higher preoperative levels of those natriuretic peptides NT-proBNP and BNP are clearly linked to worse outcomes after surgery. There's basically a straight line. The higher the BNP, the higher the risk of cardiovascular death or non-fatal MI.
And troponin, too, even before surgery?
Yes, with the newer high-sensitivity troponin tests, HSCTN, we're realizing that some patients, especially those with known heart conditions, might have slightly elevated levels even before they go into surgery. Some research suggests combining these biomarkers with the clinical risk scores might give us a better prediction, though it's not yet standard practice everywhere based on US-EU guidelines. There's also some evidence linking inflammation markers, like high-sensitivity C-reactive protein, hsCRP, especially when combined with high NT-BNP, to increased MP risk after vascular surgery.
So should everyone having vascular surgery get these biomarkers checked beforehand? What's the current thinking?
It's still evolving. The European guidelines say don't do it routinely for low-risk patients, Class 3 recommendation. The Canadian guidelines, however, encourage considering it. For patients having higher risk or major surgery, the ESC guidelines say it's reasonable to check troponin and/or BNP preoperatively, Class DIBE.
So more selective use?
Often, yes. We tend to use them in specific situations, maybe very complex, high-risk operations, patients with known poor heart function, or maybe someone who recently had a coronary stent. The Canadian guidelines are more specific, recommending BNP and T-proBNP for older patients, over 65, those with significant cardiovascular disease, or anyone with an RCRI score of 1 or more. But again, that hasn't become routine practice globally yet.
What about a simple ECG? Still standard.
Oh yes, a preoperative ECG is recommended for basically all vascular surgery patients, Class I recommendation. If there are new changes, especially in the ST segments, that might warrant a further workup, depending on how urgent the surgery is.
But old changes aren't necessarily a red flag.
Not on our own, usually. Most abnormalities on a pre-op ECG are chronic. Things like old heart attack signs, pathologic Q waves, or signs of a thickened heart muscle, left ventricular hypertrophy, can suggest a higher risk of perioperative ischemia, or MI, but studies show their predictive value can sometimes wash out when you factor in other known clinical risks. So you interpret the ECG in the whole context.
And what about imaging? Chest x-rays, echocardiograms?
Well, if a chest x-ray shows obvious signs of heart failure, that definitely needs looking into further. But routine screening echo, the heart ultrasound, isn't generally recommended for low to intermediate risk patients if they don't have specific symptoms or history pointing to a problem.
When is an echo considered?
It should be considered if someone has a history of CHF or maybe concerning chronic ECG changes. It might also be reasonable, Class IB, for patients having high-risk surgery even if they have no symptoms, just to get a baseline look at the ventricle function and valves. Sometimes in emergencies, we might even use a quick handheld ultrasound at the bedside just to check the aortic valve or LV function quickly.
Given that strong link between vascular disease and coronary artery disease, CAD, how is CAD itself evaluated before vascular surgery?
Right, we know a huge percentage of these patients have underlying CAD, maybe 50–90% based on older studies. And a fair number have significant, potentially dangerous blockages, even without symptoms. The challenge is identifying those high-risk individuals so we can try to mitigate their risk.
But you don't test everyone.
No, definitely not. For low-risk surgeries in patients who are asymptomatic or have stable symptoms, guidelines say cardiac stress testing isn't needed, Class 3.
Okay, but if testing is needed, what are the options?
There are several. You've got nuclear stress tests like SPECT, which is widely available. Cardiac MRI, CMR gives great images. Stress echo, using exercise or medication, avoids radiation, but is very dependent on the operator and reader. PET scans are very accurate, but maybe less available and more costly. And then there's CT coronary angiography, CTCA.
CTCA seems like it's becoming more common. What's the evidence for using it preoperatively in vascular patients?
Yeah, CTCA is good at seeing the coronary arteries non-invasively. Heavy calcium can sometimes interfere, but newer tech helps. Studies have shown that finding significant stenosis narrowings, and particularly disease in multiple vessels on CTCA, are strong predictors of postoperative MEZ. Sometimes even better predictors than the clinical risk scores alone.
Really?
Yes, one study found patients with more than 3 significant blockages on CTCA had a much higher MEC risk, regardless of their RCRI score. A big review also supported this: the more severe and widespread the CAD on CTCA, the higher the MACE risk.
That sounds really valuable. The sources also mentioned something called FFRCT, fractional flow reserve CTCA. What's that?
Ah, yes. FFRCT is a really exciting non-invasive development. It uses fancy computations on the CT scan images to estimate the functional significance of a narrowing, basically how much it's actually restricting blood flow.
So not just if it looks narrow, but if it's causing a problem.
Exactly. And the results from FFRCT correlate pretty well with invasive FFR measurements done during a heart cath, but without needing the invasive procedure. Since invasive FFR predicts future heart events, this non-invasive FFRCT has huge potential for pre-op evaluation, telling us location, severity, and the hemodynamic impact of any blockages found.
Okay, so after all this testing and assessment, what about actually intervening before the vascular surgery, like doing coronary angiography and maybe putting in stents, or doing bypass surgery to fix the heart first?
That's the million-dollar question, isn't it? The decision to go for coronary angiography based on non-invasive test results really comes down to balancing the potential benefit of fixing a blockage against the risks of the heart procedure itself, and importantly, the delay it causes to the needed vascular surgery.
What did the big trials show?
Well, some earlier retrospective studies hinted at a benefit, but then the big randomized trial, CRP, published in 2004, specifically looked at routine revascularization before major vascular surgery, and it surprisingly showed no benefit.
No benefit at all.
Well, it's important to note who was in that trial. They mostly enrolled patients without severe ischemia and excluded those with really critical left main disease or terrible heart function. So maybe the results don't apply to everyone.
Okay, any other evidence?
There was a smaller trial, Monaco, in AAA patients, that suggested routine angiography might be beneficial in that specific group, but it wasn't definitive. A more recent look back at registry data found that while having significant CAD definitely predicted worse long-term mortality, actually getting revascularized didn't change the overall mortality rate compared to just medical management.
So what's the bottom line from the guidelines now?
The current guideline stance, Class 1, is that coronary revascularization before non-cardiac surgery should only be done if it meets the standard indications for revascularization anyway, basically, if the patient needs it based on their heart condition, regardless of the upcoming vascular surgery. It's not recommended, Class 3, to do it routinely just to try and lower perioperative cardiac events.
So treat the heart disease if it needs treating on its own merits.
Exactly. And again, this is a complex decision that really needs that multidisciplinary vascular team input.
Makes sense. Okay, let's shift to medications. What about using best medical therapy to try and reduce cardiac complications around the time of vascular surgery? Let's start with beta blockers.
Beta blockers.
Yeah.
Yeah, the thinking initially was, okay, slow the heart rate, reduce oxygen demand, this has to be good. But then some large trials, like POIEs, came out and showed that while maybe they reduced some MIs, they were also linked to increased stroke and overall death. A bit of a shock.
So not the magic bullet people hoped for.
Not quite. The strongest recommendation now, Class 1, is just to continue beta blockers if the patient is already on them chronically. Starting them preoperatively might be considered Class 3 in high-risk patients, particularly those with known ischemia or multiple clinical risk factors, but the evidence is weaker, and you have to be careful.
Okay. What about statins? Cholesterol-lowering drugs.
Statins have a much stronger story. Numerous studies, both observational and randomized, show positive effects for patients on statins undergoing all sorts of vascular procedures, leg artery work, endovascular stuff, carotid surgery, open AAA repair. They're linked to lower long-term mortality.
And around the surgery itself.
The in-hospital outcomes are maybe a little less clear-cut in some studies, but a large meta-analysis combining trials and observational data found perioperative statin use was tied to significantly lower all-cause mortality, MI, stroke, and a composite of those bad outcomes.
So the recommendation?
Definitely continue them if the patient's already taking them, Class 1. And it's reasonable to initiate them preoperatively, Class I, ideally starting at least 2 weeks before surgery if possible.
Okay, statins look good. What about aspirin? Another common one.
Aspirin's role is trickier. We know it's great for secondary prevention, preventing future events in people with known disease. But around surgery, the big POISE 2 trial looked at starting aspirin before non-cardiac surgery and found it didn't reduce death or MI, but it did significantly increase major bleeding.
Not great. What about vascular patients specifically in that trial?
Interestingly, the vascular surgery subgroup analysis in POISE 2 suggested that stopping aspirin perioperatively didn't seem to increase thrombotic complications. However, for carotid endarterectomy, the ACE trial found lower doses of aspirin were actually better.
That was confusing.
Yeah, the guidance is currently a bit murky. The Canadian guidelines suggest continuing it, especially for carotid surgery or recent coronary stents. The ACA guidelines don't generally recommend starting or continuing it for most elective non-cardiac surgery unless the ischemic risk clearly outweighs the bleeding risk. The ACESA suggests an individualized assessment. It's not straightforward.
Definitely sounds like a case-by-case decision. Now, a really specific situation. Patients who've had coronary stents and are on dual antiplatelet therapy, DAPT, usually aspirin plus another drug like clopidogrel. How is that handled?
Oh, that's a critical one. Managing DDPT is a huge challenge. Stopping it too soon after stent placement, especially a drug-eluting stent, DES, carries a very real risk of stent thrombosis, the stent clotting off, which can be catastrophic, causing a massive heart attack.
But continuing, it increases bleeding risk during surgery.
Exactly. It's a major balancing act. The decision about when, or even if, to stop DDAPT absolutely requires that multidisciplinary team surgeon, cardiologist, anesthesiologist. Key factors are the type of stent, where it is, how much heart muscle is at risk, and crucially, how long ago it was placed. Newer generation DES might allow for shorter DDPT durations.
Are there guidelines for this?
Yes, current guidelines have algorithms, like in Chapter Algorithm 3 of the source, and consensus statements like SAS2 try to help navigate this. It depends heavily on the urgency of the vascular surgery versus the risk of stent thrombosis. It's complex.
Definitely requires careful coordination. Okay, we spent a lot of time on the before. Let's move into the operating room itself. What happens during the surgery that can affect MACE risk?
Right, the fundamental goal during the operation is still the same. Minimize myocardial oxygen demand while making sure supply is adequate. Several factors in how the anesthesia and surgery are managed can influence this balance.
Like the type of anesthesia used? Does that make a difference?
That's been studied quite a bit. The main types are local, regional, like spinal or epidural, monitored anesthesia care, MAC, and general anesthesia, using inhaled gases, IV drugs, or both. Overall, large studies haven't consistently shown that using regional anesthesia, like a spinal or epidural, lowers the risk of MI compared to general anesthesia for non-cardiac surgery.
What about the specific anesthetic drugs, like the inhaled gases?
There was some thought that volatile anesthetic gases might have heart protective effects, especially seen in cardiac surgery. But their impact on mortality or ischemia in non-cardiac patients is less clear. Some recent big trials have even questioned their benefit in coronary bypass surgery. So current guidelines say either volatile agents or total intravenous anesthesia, TIVA, are reasonable choices. Class 2.
But you mentioned regional anesthesia, like epidurals, might have other benefits.
Yes, a key benefit of neuraxial anesthesia, spinal epidural, is postoperative pain control. Better pain relief can blunt that sympathetic nervous system surge and reduce catecholamines, which is good for the heart. And some data, including a Cochrane review, suggest it might be associated with better outcomes, specifically in abdominal aortic surgery. Its ECA give it a Class 5 ONTIA recommendation for potentially reducing complications in these cases, though the SVS practice guidelines differ slightly.
Okay. What about blood loss during the surgery and needing transfusions?
Significant blood loss leading to anemia that requires transfusion is definitely associated with increased mortality across many types of surgery, including vascular. Getting a blood transfusion around the time of vascular surgery is linked to higher rates of MI, other cardiac events, and death.
Is it the transfusion itself, or just that sicker patients need transfusions?
That's the tricky part to tease out. Some studies found the increased MI risk was specifically tied to post-operative transfusions, not necessarily intraoperative ones. And of course, transfusing donor blood, allogeneic RDCs, has its own risks: fluid overload, immune reactions, infections, etc.
Is there a way to avoid donor blood?
One technique is intraoperative cell salvage, where the patient's own blood lost during surgery is collected, washed, and given back to them. While there isn't strong proof it directly reduces mortality or MAC, it does reduce the need for donor blood. So the SVS recommends considering it for procedures like AAA repair, where you anticipate major blood loss, level 1B.
Makes sense. And what about managing blood pressure during the surgery? How critical is that?
Extremely critical. Keeping blood pressure stable and adequate is fundamental. How often hypotension, low BP, happens depends a lot on how you define it, but we know that increased variability in BP during surgery, and especially a low average mean arterial pressure, AMBP, are both linked to higher 30-day mortality.
And low BP directly hurts the heart.
Yes, intraoperative hypotension is clearly associated with increased risk of myocardial injury and also acute kidney injury. Studies show both big drops in the patient's baseline BP and simply having absolute low MAP are problematic.
Are there specific numbers to aim for? What about high blood pressure?
It's interesting, the large vision study looked at this. They found intraoperative tachycardia, fast heart rate, increased the risk of MI, injury, and death. Hypotension increased injury and death, but maybe not MI directly in their analysis. Hypertension actually increased injury and MI, but seemed linked to reduced mortality, kind of counterintuitive. Bradycardia, slow heart rate, seemed protective. Other studies, specifically in vascular surgery, linked intraoperative hypotension, like MA60 or a 40% drop for 30 minutes, to increased postoperative myocardial injury. A 2019 consensus statement generally agreed that MAP consistently below 60-70 mmHg is likely harmful. There wasn't enough evidence for a strict upper limit, but systolic pressures over 160 were associated with injury MI.
Okay, keep it in a reasonable range. Lastly, for intraoperative factors, body temperature. Does getting cold during surgery matter for the heart?
It can.
Yeah.
Patients often become hypothermic during surgery, core temp dipping below 36 degrees C and 97 degrees air. This happens due to anesthetic effects, couloirs, open body cavities. We know hypothermia increases blood loss, transfusion needs, and wound infections.
But what about direct cardiac effects?
The evidence there is a bit mixed. One trial suggested keeping patients normothermic, normal temp, reduced cardiac events compared to mild hypothermia. But another trial in aneurysm surgery found no increase in cardiac events with hypothermia. And a retrospective analysis found no link between mild hypothermia and injury.
What about in AAA surgery specifically?
Their hypothermia seems generally bad. It's linked to decreased cardiac output, platelet problems, clotting issues, Worse severity scores, more EKG changes like ST depression, more VT, and overall worse outcomes in some analyses.
So the guidelines likely say keep patients warm.
Generally, yes. The AHA gives maintaining normothermia a level IAE recommendation. The SCS is stronger for AAA repair, saying maintain core temp above 36 degrees C, level IEB. So meticulous attention to all these intraoperative details is clearly vital. Okay, surgery's over. What happens after? How are cardiac complications managed then?
Right, so meticulous attention to all these intraoperative details is clearly vital. Okay, surgery's over. What happens after? How are cardiac complications managed then?
The immediate postoperative period is tricky. There are huge physiological shifts happening, fluid changes, pain, inflammation, stress hormones still high. All this can make it really hard to recognize when a cardiac complication is brewing.
And these patients are prone to silent problems.
Exactly. Patients after high-risk vascular surgery have surprisingly high rates of silent ischemia, lack of blood flow without pain, silent myocardial injury, and even silent MIs. And importantly, all of these silent events are linked to poor outcomes, including increased mortality.
So you have to be looking for trouble.
You absolutely do. You need a high index of suspicion and a really low threshold for getting an ECG and checking troponin levels, especially in high-risk patients, or if anything seems slightly off. Remember, the Canadian guidelines even recommend routine postoperative troponin checks after major risk surgeries.
What if you do find something concerning, like on the ECG?
If you see ST segment elevation on the ECG, that is a true medical emergency. It means an artery is likely completely blocked. You need an immediate cardiology consult, aiming for reperfusion therapy, usually PCI stenting, as fast as possible. The goal is often ECG to balloon inflation in the cath lab in under 60 minutes.
Wow. Any specific group that's extra vulnerable post-up?
Patients who had a drug-eluting stent, DES, placed less than 6 months before surgery are particularly vulnerable, mainly because their DAPT might have been stopped or interrupted for the surgery. They need very careful multidisciplinary follow-up.
Okay, what about managing a suspected type 2 MI post-operatively, that supply-demand mismatch issue?
The main goal there is goal-directed medical therapy. You want to enhance oxygen supply, maybe supplemental oxygen if they're hypoxic and reduce oxygen demand. That often means controlling heart rate and blood pressure, maybe with beta blockers or calcium channel blockers if BP allows, managing pain effectively. You generally want to avoid NSAIDs as they can worsen heart failure and kidney function.
What about the really tough situation? Tachycardia with hypotension, fast heart rate, low blood pressure.
Well, that's incredibly challenging. You have to rapidly assess their volume status. Are they dry? Are they overloaded? Could they be bleeding internally? Is there sepsis? You need to understand their baseline heart function and the physiological changes from the surgery. It often requires further tests, maybe an echo, close hemodynamic monitoring, and careful use of fluids, possibly vasopressors to support pressure, and maybe beta blockers if the low pressure isn't due to low output. It's complex.
And if the worst happens, cardiac arrest.
Unfortunately, cardiac arrest after vascular surgery carries a very, very poor prognosis. Outcomes are generally dismal.
What about post-operative CHF? Is that managed differently?
Postoperative heart failure is often part of that whole continuum of coronary artery disease we've been discussing. It can present atypically after surgery because of pain, sedation, other organ issues. Patients with pre-existing HFrEF, weak pump, are especially vulnerable to fluid overload and can easily enter that downward spiral of worsening function. Meticulous fluid management, close monitoring, and team-based care are crucial.
Any specific treatments for post-op CHF?
For some HFrEF patients who also have a specific electrical conduction delay, LBBB, implanting a special pacemaker called CRTD before surgery might offer some benefit. Otherwise, management is generally similar to non-surgical CHF diuretics, maybe drugs to help the heart pump better or reduce strain. Measuring natriuretic peptides can help guide therapy. But the long-term outlook for patients developing significant heart failure after surgery is often poor, so getting the heart failure specialist involved early is really important.
This has been incredibly thorough, a really deep dive into a complex and obviously critical area. If you had to boil it down, what's the single key takeaway message?
I think the main point is that cardiac complications are a major, major concern in vascular surgery. They're common, they're serious, and managing them effectively requires a really comprehensive approach, understanding the risk factors, the pathophysiology, using the right assessment tools, optimizing patients beforehand, being vigilant during surgery, and knowing how to manage problems when they arise afterwards. It's truly a perioperative challenge.
Absolutely. And this deep dive, drawing from that fantastic resource, Rutherford's Vascular Surgery, has hopefully given you, our listener, a really solid foundation of knowledge on this vital topic.
Indeed. Hope it's been helpful.
So maybe a final thought to leave you with. When you think about this incredibly dynamic interplay between vascular health, cardiac health, and the stress of surgery, what do you see as the most promising future directions? Where are we heading in terms of truly personalizing risk prediction and maybe even interventions in this high-stakes field? Perhaps mull over the evolving role of advanced biomarkers, imaging, maybe even AI as you consider that. Thanks for taking this deep dive with us today.